Thank you very much, and thank you very much for asking me to talk with this interesting title. So, is open surgery still justified when EVAR is possible, and if so, when? So, to be slightly controversial, if I put up the 15-year EVAR trial results, we already know that EVAR is not durable, and there's a very high re-intervention rate, and both the long-term results of the EVAR trial and also the DREAM trial showed that if you have endovascular repair, the probability of freedom from intervention is much lower with endovascular repair, and the graphs cross over sort of at about 5 years. And similarly, for intervention-free survival, endovascular repair isn't quite as good. So knowing that, and the NICE guidelines that Paddy presented previously, we were all shocked and stunned in the UK when our main guidance body came out saying that actually the vast majority of patients that we're performing elective aneurysm repair on, if they're fit enough, should be having open surgery. And there were a few caveats that allowed us to carry on doing EVAR. But on the whole, I would say that the vascular surgical fraternity in the UK were quite upset about these guidelines, but it was based on the evidence that they had. When I was training and a research fellow, so back in the early 2000s, there was a leading article published in the BJS by Jack Collin and John Murray, which was entitled Endovascular Treatment of the Abdominal Aortic Aneurysm, a Failed Experiment. And at the time, again, we thought they were being intransigent, a little bit Luddite-ish, a bit old-fashioned, but potentially, actually now looking back on it, they might have been being prophetic and prescient. And actually I could turn the title around completely and give a talk on this topic as well. So is EVAR justified when open surgical repair is possible, and if so, when? So open aneurysm repair. It is by far and away my favourite operation, and I think it's a good operation, and it's been much maligned. It has definitely become the Cinderella to EVAR. It's sort of out of fashion, it's not trendy, and it's definitely a team sport. Whereas EVAR is an incredible technology. It's got ever-increasing applicability. Every year the technology gets better. It becomes lower profile. We've got branched and fenestrated technology. The vast majority of us who do EVAR now use percutaneous access. And it gives us ingenious solutions to many problems. We've got off-the-shelf solutions, but we've also got the ability to bespoke make a graft for any patient. And going back to Michael Jacobs' talk earlier, what does the future hold? Will we be 3D printing grafts in theatre? And what about biological grafts? Lots of opportunities going forward. So the really sticky problem, I think, is that there isn't one answer. There isn't, a panacea of everybody gets EVAR, except for the occasional patient who has to have an open operation. It's not about the operation, it's about the patient. We must use our clinical and holistic acumen to make the right decision for each individual. EVAR, frankly, is not durable and does require lifelong surveillance. And open surgery carries a much higher operative mortality initially and takes longer to recover from, and isn't a totally benign procedure in the long term. It does have some complications, but in the big randomized control trials, it does seem to be better and more durable. So when would I say that open surgery is definitely preferable? I think if you've got a young patient with a long life expectancy, knowing the data that I know from the trials, I would be very pragmatic with the patient, but I would explain that I would think that that was their most preferable option. I do believe that in connective tissue disease, particularly Marfan, that stent grafts are not ideal. They rely on technology that involves pushing out against an already weakened aortic wall. And I think it's controversial to use stent grafts in connective tissue disease. I do use them to get myself out of trouble in emergencies. But pragmatically, I think if they're young, they should have an open operation. I think the combination of aneurysmal disease and occlusive iliac disease often do better with open surgery. And there is a group of patients where we all know, if we sit in an MDT regularly, where actually the open surgical option is far less complicated than the endovascular one. So in a patient with a juxtarenal aneurysm that you may in fact be able to get away with an infrarenal clamp, in fact, because of the diseased aorta higher up, would end up with a type 4 or even a type 3 endovascular repair involving fenestrations for all visceral vessels and cannulation of those and the associated risks. And then I think, obviously, so my big preference in the presence of infection, if I'm doing it electively, would be to do open surgery so that I can debride the surgical field. There's no doubt that if you're going to use EVAR, you have to stick to the IFU. I think as a vascular community, we have got sloppy, and we've wanted to push the boundaries with new technology, and we've compromised on length and diameter of landing zones, and it's given us worse results, increased reintervention rates, and aneurysm-related death. In the UK, and I know in other countries, we have a well-designed and well-executed registry, and we're now collecting device data. And it may help us identify problems earlier than in the past. And those of us that do a lot of vascular surgery do not want to see another horror like 𝗟𝘀𝗃𝗃. And actually, for once, we're taking some leaves out of the orthopedic surgeons' books because they've had the bone and joint registry for years. And I think the device data is going to be very interesting. So actually, how do you make a decision about who gets open surgery? There is no doubt that we are moving more towards shared decision-making, where the patient becomes more involved in their care and has to understand the treatment options and the supportive care available. And you have to come up with a personalised treatment plan for each individual patient. So very much like Paddy's message. I don't think I could give this talk without talking about frailty and life expectancy. Everybody's getting older. Everybody has more complex medical problems. There's a lot of loneliness, people living alone, loss of independence, and that's been exacerbated by the COVID pandemic. Vascular patients are particularly frail, and they have significant risk factors for elective and emergency surgery. And the patients have to understand those risks in order to make a decision about their care. And having moved jobs around the UK, I am more than aware that it's not all about anatomy and age. If you actually talk to the patient and you discover that they're the main carer for a spouse who's ill, they don't want to be away from them for a long time. They want to have endovascular repair. They don't actually care about the differences between the techniques, but for them socially that is the right decision. If they live alone and they're worried about losing their independence, again, they may pick EVAR. They want to get back to their dogs, cats, horses, whatever it may be, and they don't want to be in hospital for a long time. They want to be able to drive again. And then I've moved recently to the north of England, where there are an enormous number of farmers who are very fit, run their own businesses, obviously. They want an operation that's durable. They never want to come back to the hospital again. They don't want CT scans yearly. They don't want to waste the time. They want an open operation, and they'll do fine. So I think my message is you really have to talk to your patients and find out what's important to them in their lives to make the right decision. And again, harking back to something that Paddy said, just because we have a hammer, not everything needs to look like a nail. Not everybody needs an operation. In the vast majority of cases, aneurysms are painless and do not impact on quality of life. And doing nothing is an important option to consider. So, if you're not going to do open surgery very often, how do you train people to do it? There is no doubt that in the UK, since the publication of the 𝗙ice guidelines, we are in fact doing more open surgery than we were, but EVAR is by far and away the commonest operation to repair an aneurysm in our country. So open surgical repair has become a specialist operation, and I think it should be done in high volume centres with aortic open specialists. Thank you very much.